Welcome, everyone. My name is Sarah Morrison, and I'm with Foothold Technology. Thank you all for joining us for today's webinar. We have a lot of information to get through, but we'd like to answer as many questions as possible. So if you have a question at any point during the presentation, please let us know by sending a chat message to Foothold Technology. At the end of the presentation, we'll go through these questions. Foothold is excited to be part of the national conversation surrounding supportive housing and Housing First. We've created a supportive housing resource center on our website where members of the community can ask questions, provide answers, learn about events, and read articles. Following the webinar, you'll be directed to the Supportive Housing Resource Center. I encourage you to explore. We will also be speaking at the upcoming Housing First Partners Conference at the end of the month in Los Angeles. Be sure to check out our session if you'll be at the event entitled Using Data to Address the Homelessness and Behavioral Health Crisis. And now I'm going to pass it over to Paul Rossi and Lindsay Cassal.
Hi, Sarah. Thanks so much. As Sarah said, my name is Paul Rossi. I'm the Director of Client Services here at Foothold Technology. And we're joined today by Lindsay Cassal, who's the Housing First Program Manager at Pathways Vermont, who I'll introduce in just a few minutes. What we wanted to do today was walk you through a discussion basically that we'll be having a presentation that Lindsay will do together with me about using data to make decisions to drive performance in Housing First programs. And I wanted to first start out with a little bit of background on the evolution of data collection in the world in which we all live. I know that we have a mix of attendees today, folks that already use awards or some other kind of electronic health record in some programs, and others that may use any one of the following types of data collection tools that I'm going to talk briefly about. As we know, the world of data collection and data utilization has really evolved over the last probably 15 to 20 years, and even in the last few years since the Affordable Care Act and meaningful use incentives and, with, even greater collaboration across the federal partners in the fight to end homelessness, we've really seen a forced sophistication, if you will, in data collection and management in nearly every community. And as we've become more reliant on data to drive agency decision-making, our relationship to data and our understanding of data has really evolved. For as long as human service agencies have been providing services, they've been collecting data on the individuals and the families that they serve. And the tools in most cases have grown to be more comprehensive and really provide a more interrelated view of our clients, or those that we call guests or consumers, individuals, whatever the name is for the folks that you serve in your programs. And, of course, paper-based charts. Paper was king and really remains ever present in our offices today. There's a huge initiative to go paperless. And while many organizations have been striving to get to a paperless environment, it's really still a very small number of agencies that have gotten there so far. Personal computing and the development of software for the office really led to utilization of tools like spreadsheets that provide some advanced functionality relative to managing data and reporting on the data collected. And these spreadsheets and related products still have a huge presence in our workplace today. Also, with the introduction of the personal computer and software came the presence of, those standout colleagues of ours that are still in each of our offices probably, that learned how to set up custom databases to organize information differently and more specifically suited for the programs that the data is being collected for, which meant that organizations within a program could get much more specific about what to collect, how to collect it, and now they had a tool to collect exactly what a funder required, and it really dramatically reduced the amount of time needed to aggregate data into reports, and whether those reports were for funders, for the community, for the executive leadership of the organization, or for the team that's providing the service itself. The value is in many ways equal, and we'll explore some of that later through Lindsay's presentation. Around the same time as all of this was happening, a marketplace of electronic case management and chart records, or electronic health records vendors like Foothold, started to develop and improve products that could go beyond a simple single machine-based approach and be installed across a network to help join program data. And it really moved the bar as it related to integrating data collection across an agency. The infrastructure to support client-server applications is pretty expensive and complicated, and outside of local governments, state governments, and that sort of thing, most folks have been pushed to the cloud. Many of the applications that lived in that server-based environment or client-server-based environment have been converted to live in the cloud or the web, basically, as we understand the cloud to be. And many new products have been developed to utilize the internet as a free network. So moving on to the benefits of an electronic chart, what are the advantages and benefits of an electronic chart? Well, in standardization, we talk about agency data collection and charting procedures that can be standardized to serve individual programs, departmental data collection, and also still keep the agency's data collection routines consistent across all the sort of operating units in an organization, which helps support the executive, funder, and program reporting needs that we're going to talk more about. Improved audits are a byproduct of the standardization of workflow and the data elements. Requirements built right into the data collection tool ensure that users hit all of the right data elements and that they're collecting all those required fields. Essentially forces them into doing data entry correctly, not giving them the option to skip blanks on paper forms and that sort of thing, which has plagued program reporting in the past. With all of that comes staff accountability, and with all these reporting options, that are typical in an electronic chart, things like audit trails and charting reminders, management can stay on top of program activities from a central location. You no longer have to travel to a program site or have data brought to you in the form of a stack of files or paper reports that somebody else has to put together and assemble to you. Now you can look at this information virtually everywhere. While there's sometimes a strong resistance to learning a new tool or changing a workflow, there really is the promise of increased efficiency. It's not something that most people feel at the outset when they're implementing a new data collection tool or even bringing a new program onto an existing tool. It really does feel like you're never going to get that time back. But you really do. It really does happen. Staff will get more time to provide services, and the value of real-time collaboration across multi-site organizations, it can't be discounted. In solutions where billing is integrated, and most are these days, particularly as we shift to a lot of managed care in our space here, there's a seamless link between services and billing that enhances efficiencies outside of those units that are just client service focused. So that's sort of where we are, just scanning folks that have registered. Like I said, we're appearing to be a mixed group here today, some that are familiar with awards and how to navigate through awards. Others are using different chart records or exploring integrating a chart record into an electronic chart record into their organization. Like I mentioned earlier, we're pleased to have Lindsay Cassal with us. Lindsay is, like I mentioned earlier, the Housing First Program Manager at Pathways Vermont, and Lindsay's been with the Housing First team as a Housing First team leader. That's how she joined in 2012 after relocating to Vermont from New York City. Since joining Pathways Vermont, she has transitioned into the role of Housing First Project Manager. So, Lindsay, welcome.
Thank you. Thank you so much for having me.
Absolutely. So Lindsay is going to give us some background on Pathways as an organization, how they use data, and some of the demonstrated impact of the reports that they actually use. So I'm going to let Lindsay take it away.
Thank you, Paul. So just a brief history about Pathways Vermont. Pathways is a nonprofit organization that seeks to provide increased access to needed services in the areas of choice, connection, and home for some of the most vulnerable people living here in Vermont. We have a couple of programs that support that effort, and as Paul mentioned, I work on the Housing First program. We are a relatively new agency. We began providing services in late 2009, so we're relatively new, and we've grown a lot over the short time that we've been here in Vermont. something that I think informs how important data is to Pathways is the fact that we started here as a demonstration project. Pathways Vermont was our agency was initially called Pathways to Housing Vermont, and that's significant as an affiliate to the Pathways to Housing National Program. We started as a demonstration project to determine whether or not housing first services were something that was needed and necessary in a very rural state. As some of you may know, Housing First is a model that's gained a lot of popularity and been demonstrated to be very successful in some very urban areas in New York, Philadelphia, DC. And so here in Vermont, we had a challenge to say, you know, is this something that's worth doing on such a small scale, and is it a needed service? We started with a grant through SAMHSA in just one office. In 5 full-time equivalents, and now here in early 2016, we have over 71 full-time equivalents in 5 different projects. So as you can imagine, we've grown tremendously. Additionally, we've seen some major successes in that our SAMHSA grant was a 5-year grant. And when that grant came to a close, we were able to replace our services funding with Medicaid billing, which has given us a sustainable way to continue to provide services here in Vermont, and concluded our demonstration project with demonstrating that this was a needed service here in this small state. Additionally, we are the first agency to be newly designated as a specialized service agency, so to be included in the system of mental health care here in the state. And we currently serve over 1,000 individuals at a given time statewide. Next. Just a brief look at some of our projects. We currently have 5 projects that support folks in accessing increased connection, choice, and home. We have a community center called the Wellness Co-op, which is a drop-in center available to anybody in the area of Burlington, Vermont. It provides drop-in areas. They have a community kitchen and do community meals along with a variety of different groups. We have the support line, which is a statewide line available to any Vermonter to call. It's currently open second shift from 3 to 11 p.m. 7 days a week, and we hope that one day this will be a 24/7 program. This is a line for folks who are experiencing distress to call, who might otherwise call crisis or emergency services to have a listening voice and someone to talk through their issues with. We have the Soteria project. Soteria is our newest project. It's a 5-bed residence for people that are experiencing an altered state or an early break of psychosis. It's a program that is designed to divert folks from a traditional hospital stay, and that is focused on the idea of being with people and supporting them to kind of navigate their own experience and come to their own conclusions versus a very medical model approach. We have the Supportive Services for Veterans Families project. This is a rapid rehousing project that supports veteran households who are either homeless or are newly homeless or who are at imminent risk of becoming homeless to get back into housing and to address the barriers that are causing them to be in housing crisis. And finally, we have our Housing First program, which I'm a part of, and Housing First is a permanent supportive housing project for individuals who are experiencing chronic homelessness. Here's a definition of Housing First. Housing First provides immediate access to what's called permanent supportive housing for people who are experiencing chronic homelessness and who also have significant mental health challenges. By immediate, we mean without barriers. So we don't require that people demonstrate treatment compliance, a period of sobriety, that they have income, or anything like that in order to access housing. The idea is to get folks off the streets and into housing as rapidly as possible. By permanent, I mean that people sign year leases with the option to renew. There are no time limits on the project. And in chronic homelessness, as some others might know, is defined as individuals who have long histories of homelessness, so who have either been homeless for a year in this current period of homelessness, or who have had 4 or more episodes of homelessness in the last 3 years, totaling at least a year's of time. Some demographics about homelessness in Vermont. We are a small state. The state population is only about 600,000. So these numbers, while relatively small, are significant given our small population size. We have annually about 1,500 individuals who experience homelessness, and of that, 166 individuals experience chronic homelessness, so those really long periods of homelessness. 119 are veterans, and almost a third have a psychiatric disability. The state has limited resources to support this population. Their primary resource for folks is shelter beds, but the bed number is limited. There's about, a fifth of the total beds needed exist in the state. Additionally, many of the shelters have restrictions on who can enter. They have usually requirements around substance use, that some people cannot be using substances, that they have to be able to interact appropriately in a group environment. And to account for the limited shelter beds, the state funds a program by which they provide motel assistance to individuals experiencing homelessness. This is an expensive project that, is a temporary solution, and this is part of the framework or the background of why the Housing First program has come into this state, is to support a permanent solution for people experiencing homelessness. So we're obviously here to talk about data and how data drives our decision making. Data has been a very important part of the Pathways Vermont story. As I said, we initially started as a demonstration project. So we started with the idea that we had to prove ourselves, right, to prove that this was a worthy project to be doing in such a small state. And we had some evaluation that was tied to receiving funding in the early stages. We did some SAMHSA surveys. Additionally, our other programs have had some program-administered surveys. For example, at the Wellness Co-op, there's a survey that kind of is a longitudinal survey that is given to folks over time. And we also have one of our more recent projects, the SSVF program, which works with veteran households and is part of an initiative to end veteran homelessness nationwide, has a periodic self-administered computer survey. On a record-keeping level, we do use an electronic medical record. We use Foothold, and we have important measures that we document there. We measure incidents on both a program and agency-wide level, along with a lot of client-specific data around service utilization per person, around meeting goals, and other life achievement measures. And finally, we use data in terms of feedback. So on a staff level, we have folks complete post-training or event feedback forms. On tenant level, we have tenant forums and utilization surveys, and we use this data to inform how we operate. So to make decisions about how something as simple as like an all-staff event may be run, or to make big decisions about how the program structure is implemented. This is an example of a report that we often pull from Foothold, and this looks at the number of individuals residing in different institutions and the length of those episodes, and it actually gives even an average length of the episodes. This is important for us, and there's a graphic that we'll look at later on in terms of informing the impact that we're making on the people that we're serving. Ultimately, we want to see people spending more and more time in the community and accessing, less institutional time. And we can use this data on either a client-specific level to see, is Bob spending less time in some of these places, and also on a program-wide level. Ultimately, are we, saving the state's resources by supporting people to, spend less time in institutional places? So I want to talk about some of the ways that Pathways has used data to enhance our services. And the first that I'll talk about is as a mechanism for continuous quality improvement. So we use this, as I mentioned, we track incident reporting. And an incident pathways is anything that, causes harm or has risk of causing harm to either a participant in services or to an employee. We can have a graph here that you guys can see in terms of the types of incidents over a period of time, and we can use that data to make recommendations about how we're operating. So, if we see 5 different incidents of the same type, we can question, do we need a different type of training for staff? Do we need to make a policy change to prevent incidents? On a client-specific level, or if we're seeing the same type of incident occur over and over again for an individual, we can see how that would adapt the service structure for that person. Additionally, we use this as a performance measure that we use actually just in a simple way to report to our board of directors. We look at kind of standardized outcomes for the various 5 programs that we serve. So we use a results-based accountability structure, and we determine, these are the indicators that we always want to look at. And then we can track over time, are we meeting those indicators? Are we seeing improvement against a baseline? Additionally, data has been incredibly important in terms of reporting to funders. As I stated, we started under a 5-year SAMHSA grant, and reporting was an incredibly important part of us maintaining that grant and also us proving our need to continue to exist following the grant. We're able to create reports within Foothold that we can replicate on a consistent basis, and that really saves our staff time in terms of we don't have to build a new report every time that we need to, provide a quarterly update to a funder. We look at things like service utilization, so how many contact hours are staff spending with people. An important measure for Housing First is where are those contacts being made, right? Are we doing the majority of providing the majority of service in the community, or are we often seeing people in office settings? We can look at demographics. We can look at things like what proportion, of folks that we're serving have a military background, what proportion of folks that we're serving have increased their income over the time that they've worked in our program. And we also look at progress towards other goals. So we use service planning as the base structure for the types of supports that we provide to people, and we can see over time if people are making progress towards those self-identified goals. With having this data context in mind is very important because it allows you to show funders that what we're doing is working in a really consistent way. And that makes it more likely, and it has benefited us to say that, we want to sustain services and we're going to look for, a way to fund you after your grant ends or to renew grants or things like that. Additionally, we've used data to engage the community. One of the things that we enjoy doing is we produce a monthly newsletter. And some of these graphics on the bottom are things that you might see in our monthly newsletter. Again, we've picked kind of the outcomes that we always want to look at, and then we report on those same outcomes each month. Not only does that, I think, build confidence in the community in terms of they're seeing progress towards the things we've said that we will do, but I think it's also a motivator to see the numbers and to see, that things are changing or moving in the right direction. I think that the other thing just to say here would be that, one of the main goals of a Housing First program is to end homelessness. And this kind of data-driven decision-making also sees, are we making an impact towards that? Are we working towards that shared mission and goal? We've also used data to inform our operations. So one way that I've used this on the Housing First program is as an employee performance measure. A lot of our positions are, as I said, field-based positions, and they require a good amount of direct service in order to be providing quality service to individuals. So something that we can track in Foothold and that we use in employee evaluations is tracking how much time are we documenting? How much time are we spending in the field? How much time are we spending coordinating on individuals' behalf versus spending time directly with them and supporting them to coordinate on their own behalf? We've also been able to set benchmarks that not only ensure that we're providing good quality service, but also ensure that what we're doing is sustainable financially. As I said, we transitioned to Medicaid funding just a little bit over a year ago, and part of this was building kind of an algorithm about how much time do we need to spend in the field providing services to sustain ourselves financially. And we were able to set some benchmarks there. And this is kind of a way that we can work within the Foothold, like the database system, in a way that's organic. We can anticipate, a lower billing week because we have 3 holidays in that week because it's, Christmas time and things like that. So it's a way to dynamically engage with our data. And finally, I think that we've used data to say, why does this matter? Why fund these types of programs, or are we really making a difference? One of the measures that we've used to kind of look at that is a self-assessment tool. So individuals in our Housing First program will complete a self-assessment annually. And so over a couple of years of time, you can see on an individual and on a program level, on a number of different indicators, whether or not people's lives are improving, or if they're reporting that they're seeing a change. In this table to the right is an example of some of that data. You can see here that the greens would be a positive change, while the reds would be a negative change. And we can look at, how statistically significant are some of these numbers. And Spinal Slide is one of my favorites. It's one of my favorites because I truly believe that this is the slide that allowed us to sustain our funding when we switched from SAMHSA and looked to replace our funding with Medicaid. This is something that we were presented to the legislatures in terms of when they were looking at which projects to fund and whether we should continue to fund the Housing First program with Medicaid dollars. This is a data set of a cohort of 129 Housing First participants. We looked at where they were in the 6 months before coming into the Housing First program, and what the measure that we used for that is called a follow-back calendar that essentially walks the individual through saying, well, where were you staying, on this night, and where were you the night before, and to kind of track where people were. And then we looked at the 6 months after coming into the Housing First program. And we were able to see that with this population of 129 individuals, incredible cost savings for the state. Over $1 million in cost savings in psychiatric hospitalizations, over $500,000 in correctional dollars, and over $100,000 in motels. So this was an incredible thing, I think, to be able to present and say, this is what this program is doing, and this is what it can continue to do.
Great. I do have some questions for you.
Yeah.
So perfect. So that was a great walkthrough, and I want to go back and touch on a couple of things that you said, sort of generally about what you're doing. But I think I had a question too around the Housing First model as you implement it there in Vermont. When we showed the slides with the numbers, with 16 shelters and 340 beds, and the cost associated with vouchering folks to motels where there's overflow and that sort of thing, I don't imagine that there's a lot of available housing stock that's just waiting to be leased up by Housing First providers in Vermont. And the question, I guess, that I have is, how difficult is it to maintain folks where they are, or what do you do? So after you engage with someone that needs to be housed, if you don't have a unit that's available for them right away, what are your options to keep them connected, to keep them safe, to keep them on the path to housing while you're securing the unit for them?
That's a great question. I would say that, so the intention is to provide access to housing as immediately as possible for individuals. So most of the time, we're looking at, our hope is to be looking at a several-week period between intake and being able to offer somebody a unit. And one way that we've been able to do this is by developing connections with landlords so that the limited housing stock that's out there, people know about us and are willing to provide apartments when they do have them. Something that's unique about Vermont versus some of the more urban areas is that the landlord pool is really, usually individuals who own one or two maybe buildings or maybe even one or two units that they're renting out versus these big property management companies that you might see in a more urban place. So, I think that our first strategy is to try to limit the amount of time that people are without housing as quickly, as much as we can. And then, of course, the second thing that does happen, Paul, is if it does take us some time to find housing, or if we are in a place where we're showing an individual multiple apartments before they find something that works for them, we're supporting them, through accessing other resources, which can be the shelters or motel assistance or other temporary resources while we're in this engagement process.
Right. It's interesting to hear you say the shelter, because I feel like oftentimes, as the shift through that HUD's been trying to make at the national level, they finally have come around to calling it housing first. They were using rapid rehousing, sort of a thing, this idea to move people out of homelessness as quickly as possible. But I feel like in many communities, shelter has really become a dirty word, but it really is it feels like in some instances a really necessary resource to keep people, or to give people a location off the streets, out of harm's way, ideally, until they get housed, until that unit's available. So it's interesting to hear that you say that that's part of it, as well as the vouchers. In terms of managing the housing, go ahead.
Just one quick thing to say on that. I think that when we talk about ending homelessness, one of the kind of terms or catchphrases that's often used is the idea of functional zero. Mm-hmm. And so what that means is that I think that we acknowledge that there will likely always be a group of people who at any given time is experiencing an episode of homelessness, right? But what we want to look to do as a nation and as individual communities is to limit those episodes of time, right? So I don't know that there will ever be a time where we would never need a shelter, for a night or a week or something for an individual. But I think the intention is to keep it very, very brief and to, as quickly as possible, move people into a permanent housing option so that they're not experiencing long shelter stays or have no way out of an episode of homelessness.
Right. Thanks for explaining on the functional zero. I know that term is used particularly around all of the press relative to solving veterans' homelessness or ending veterans' homelessness in many communities. And the functional zero concept, does account for the disconnect when we hear that homelessness has been ended in a particular community, yet on our way to wherever we heard that story, we passed a homeless person. Your point, I think, is well made there in terms of having the resources in place to effectively end it, not creating an environment where no one will ever be homeless again. It's about limiting that time. I want to talk to you for a couple of minutes about the shift to Medicaid funding. I know that a lot of folks have talked about a lot of the resources that go into supporting individuals in supportive housing, the payer for those services is in many ways shifting. I know that HUD, for instance, is trying to get out of funding services and would like to put more resources towards, sort of brick and mortar housing. Medicaid, of course, has picked up a lot of those services, and you talked about a third of the population in Vermont having, or of the homeless population, nearly a third, having a psychiatric disability, and Pathways Vermont being designated as a community mental health agency. How do you tie together all of the resources? How do you manage you know, the data, and are you exchanging data with any other providers in the community, maybe through the HMIS or outside of an HMIS, around the populations that you're serving in common?
Yes, that's a great question. I guess I'll first start by saying that yes, in this moment with our Medicaid funding and the funding being funneled through the Department of Mental Health, Pathways is being funded to provide mental health services in a particular way, right? Through a housing first model. In terms of how we interface with other agencies, whether that's other mental health agencies or other housing providers, we've done that in a lot of ways. I think an exciting conversation that we've been a part of more recently is the coordinated entry conversation. HUD has mandated that communities kind of work together to address homelessness through this coordinated entry system. And this is a way for us to interact with other providers who are providing, homeless support services or housing services to kind of see who are the individuals in the community that are in need of services, and then which agency has the capacity or might have the best success in serving those individuals.
And in terms of the mental health services that you're providing within the context of the Housing First model, did it mean for you a shift in the way that you're either capturing the data, documenting, I guess also because it's one thing to collect a data element that is going to sort of get mixed into other data elements to demonstrate sort of how something looks in your community or a level of service. It's another, there's greater accountability, if you will, when you're submitting a number to Medicaid, specifically for payment of provision of that service. When you made that transition from perhaps the SAMHSA grant to now the Medicaid services, did you find yourself having to retrain both staff, the users, if you will, that are collecting the data, as well as those in the agency that are monitoring the data to ensure that everything is sort of auditable and audit-proof?
Yes, absolutely. This was a big part of our last year of transition. We were fortunate in that we've always used Foothold, and we've always done per contact notes for serving individuals. Okay. But with the Medicaid structure, we did have to adapt our system to accommodate the very specific Medicaid, approvable language and the service types that we can bill for. So we had to retrain our staff on, what does it mean to provide, a community support individual service under, our CRT program versus our fee-for-service program. And it was a different language, essentially. Medicaid also has a bunch of different measures that you've got to hit every time that you write a note. So doing a lot of quality assurance to be sure that staff are well trained enough to know to hit those measures so that we can bill for the particular service type that we're looking for. Was a big part of, what we've done over the course of this year. But I think that, I guess, to Foothold's horn for a second, I think that it was very lucky that we already had this system and that we were able to, work with you guys to adapt the system to meet our needs, not only so that we could retrain staff when we needed to, but also so that this system the Foothold system could interact with our billing system, and we can kind of seamlessly pull reports to bill out to Medicaid to make sure that we're receiving that needed income to continue to provide service.
Great. One question, I know that that Housing First is your program area focus. One of the things that was mentioned earlier in regards to the SSVF program was the survey, that there was a self-administered survey. And I was just curious, are you familiar with how that's administered? Is it like a kiosk kind of environment, or do they, is it paper-based and then somebody else keys it in? How does the person that completes that survey interact with the survey?
It is electronic,
okay.
And I believe the way that it's been operating now is that the staff, our staff bring that survey to the individual or to the household to complete, and then that gets inputted, electronically, and then it goes to the VA for kind of bigger level monitoring. Gotcha.
And you mentioned also a self-reported outcomes process where you, under your demonstrating impact slide, with self-reported outcomes, how do you collect that data? Is it just worked into regular interactions with staff? I know that you said that I think you administer it once annually. So is it something that the client just sits down and completes with someone, or is it on their own? How does that work?
Yeah, the way that we've administered that is by a paper packet that we give out annually to people. We definitely offer staff support, or if people feel comfortable or would like to fill it out themselves, that's fine. Then we take the paper report and we input it into Foothold electronically, which allows for us to actually do the scoring. So then Foothold kind of pre-does the scoring, and that's where we get some of these outcome numbers that I've talked about in terms of being able to demonstrate whether or not people are, feeling better about some of these indicators, or, or things are feeling worse. Okay.
And one additional question before we open it up to folks that are on the call, and I know that we do have some questions in the queue already. In terms of monitoring program performance, and one of the things that you mentioned were around incidents and tracking different kinds of incidents. And I think the graph was hard to read for some of the folks on the phone, but you cover quite a number of different incidents that you're accounting for in the program. I'm curious if there are any stories that you can share, perhaps about how a certain spike in incident may have altered program design or changed some course of action for you at the program director level.
Sure. Let me just think about that for a second. That's a really good question. Let me see. I think that so I guess one example that I can give is that, one of the goals that's universal to all of the Pathways programs is to support people to remain in the community in a sustainable way, and to prevent accessing crisis or emergency services when possible. So one thing that we saw as a trend in reviewing incidences was that people were expressing strong feelings, right? So feelings of maybe not, in a clear intent or plan to kill themselves, but some suicidal feelings, and that staff were often responding by kind of immediately calling crisis or calling 911 and getting emergency services out there. And so this, seeing that kind of in an incident reporting forum, that those crisis calls and emergency level incidences were happening, we were able to say, well, what kind of training, might we do with staff to support them to be able to, engage in some of these difficult conversations in a way that, might not have to lead to an emergency service outcome. And that was, that's been an important tool for us.
Great. That is interesting. We do have a couple of questions, or at least I can see one here on my screen. And if you do have other questions, if anybody in the audience has any questions that they'd like us to ask, we can do that with the time we have left. But one of the questions that came in from Chantel in Southern New Jersey is, what kind of tenant forums have been done with consumers in your organization?
That's great. One of the standard forums that we have for tenants to provide feedback on the program, which is a really important, part, I think, of doing Housing First well, is we have a quarterly standing committee meeting. This meeting has a kind of a standing group of participants in the meeting, and each time is also welcome to any current or former participants in the program or any family or friends of that program. And this is an opportunity for, in a relatively structured way, but certainly with a lot of conversation, for tenants and participants to give feedback on the program. We review things like the qualities that they're looking for in staff if we're doing hiring. We look at kind of on a bigger picture level, some things like incidents or grievances that have been done over the course of the year, and ask them to help us to, inform whether or not we need different policies or procedures around some of these things. We've talked a lot in these forums about the Medicaid transition and whether or not on the ground level, on the service level, if people have felt a difference in the way that we provide services. And, I think that's been a really a healthy way for people to kind of engage with the program and to provide suggestions, and we certainly use those suggestions to influence some of our decision making.
Great. Sarah, there are a couple of other questions, I understand. Can you read those?
Sure, yeah. We have a couple more that came in, and the first is, have you provided housing first for families?
Yes, we have. We more often see individuals, and I think that part of the reason for that is because we're supporting the chronically homeless population, you know, and I think that it's more likely that an individual is experiencing chronic homelessness than a household, at least here in Vermont. But yes, we certainly support many partnerships and some families with children under the age of 18 as well.
Great. And the next question is, what case management models do you utilize?
That's a great question. We use an ACT team, an assertive community treatment team, and this is the way that Housing First services are traditionally provided. It's a team model by which all of the team members work together to support the caseload for the community. So rather than having, you know, individual caseloads, the team supports the community-wide caseload. And the ACT team is pretty specialized. So we look to hire people who have kind of a specific skill set around nursing, psychiatry, substance use support. We've have had computer literacy and wellness specialists on our teams, a wide variety of services and support.
Great. Well, I don't see any more questions. So I think that if people have additional questions, I've put up the contact information for both Paul and Lindsay, and they'd be more than happy to answer any questions you might have. And I just wanted to remind you that after the webinar, you'll be taken to our Supportive Housing Resource Center that has a whole wealth of information for articles, events, different forums that you can communicate with others in the community at. So I encourage you to explore that when you get taken there. And then Foothold will also be at the Housing First Partners Conference doing a similar presentation. That's in Los Angeles on March 25th. And the presenters are Paul, who's on this webinar, Mary Simons from Open Doors Homeless Coalition, and Daniel Farrell from Help USA. So if you're going to be at the conference, we hope you'll come and see our presentation. And thank you so much, Paul and Lindsay. This was fantastic. And we'll talk to everyone later.
Great. Thanks, Sarah. Thank you, Lindsay. I appreciate it. And thanks, everybody, for joining us.
Thank you.